Great, thanks. So this is the project that we've been working on for the last few months about using medicines as a proxy to assess the impact of COVID-19 on cardiovascular risk factors and also future disease. So this is work that's been done mainly by Caroline and Rohan, but also a lot of other people have contributed to it. And just to say that what we're presenting today is data from the English TRE, but we're hoping to add Welsh and Scottish data. Next slide.
Oh, sorry, I skipped on. Bear with me. Yeah, sorry.
So just by way of background, what we were trying to think about is if we could use a medicines lens to understand the impact of COVID-19 on cardiovascular risk factors. So whilst we might be able to measure or record diagnoses, one way to understand if risk factors and particularly their treatment has changed is actually to look at the medicines that are prescribed for cardiovascular risk factors. So that includes things like high blood pressure, high lipids, atrial fibrillation, diabetes, and so forth. And if the trends may vary by key characteristics, so things like ethnicity, region, age, and gender. And this is important just because the way risk factors are normally picked up in routine practice pre-pandemic was through face-to-face consultations and frameworks like the Quality Outcomes Framework. But obviously those have all been suspended during the pandemic. So it's actually quite difficult to get a handle on how things are being picked up and actually if things are coming back on track. So that's why we thought actually using a medicines lens might be a slightly different way to think about things. And then if we can also quantify the implications of non-treatment by looking again at medicines, this might tell us, who to target and where to target. And as I've mentioned, the results presented here are from the English TRE, but currently working on Scotland and Wales data. So Caroline's going to go through some of the results that we've got, and then I'll just pick up at the end to talk about kind of a shiny app that we've created as well. Over to you, Caroline.
So as Reecha said, so in this project, we've very much taken a medicines perspective. So we've looked to the sort of two main data sources for medicines within the English TRE. So the dispensed data on the left-hand side and the prescribed data on the right-hand side. And you can see that, straight from the top sort of box there, that there's quite a large difference in the number of medications available in those two different data sources. And that's because the dispensed data is effectively all dispensed medications, whereas the prescribed data reflects a selection of medications that were considered to be of greatest interest for the consortium. And then what we've done is essentially we've applied the same inclusion criteria to both data sets. So we start with doing, quite basic inclusion criteria. So they have to have a valid ID, valid date of birth. They had to be alive on the first date that the dispensed data are available, which is the 1st of April 2018. They had to have a value for gender of 1 or 2. And then we moved on and we said that the medications had to be from the BNF chapters 1 to 15, which are the medicines themselves rather than things like dressings and syringes. The LSOA region area had to be equal to England. And then moving down, they had to be adults, so that the age they had to be dispensed to a person who was greater than or equal to 18 years and not older than the oldest living person in England. And then we moved on to sort of categorize a group of medicines which we called CVD medicines, which I'll talk a little bit more about on the next slide. And then the final data set that we looked at was what we called incident CVD medicine. So it was the first time that someone was given a medicine within a particular CVD subgroup. Then in addition, and just within the dispensed data, we looked at stratifying by the characteristics of interest that Reecha described. So age, both as a binary variable, but also in 10-year age bands, gender, by ethnic group, according to regions within England, and according to the CVD subgroups, which I'll describe now. So as we said, we looked at basically we went to the BNF chapters 2 and 6, and by drug substance manually assigned those to the 11 CVD risk factors shown on the left-hand side. And so that was done independently by 2 clinical pharmacologists. And it's worth saying that each medication can only belong to one of those subgroups. So in reality, probably, well, definitely some medications will be being used for, say, both hypertension and heart failure, but we would assign them probably in that case just to the hypertension category. But that's how we came up with our categorization of the CVD medications. So turning to some of the results, so this first results slide shows the trends in a common group of CVD medicines that were available in both the prescribed, which is the blue line, and the dispensed red line data set. And so that you can see that there's this mark, and the dotted vertical lines indicate the timings of the first, second and third national lockdowns in England. And so you can see that in both dispensed and prescribed data sets, we see this marked uplift ahead of the first national lockdown. And that's as much as 17% year on year, March 2020 compared to March 2019 within the dispensed data. What also we observe is this, the gap between the prescribed and dispensed data, so I guess that primary adherence, narrows after the first lockdown and continues to narrow as time goes on. So turning just to the prescribed data, we fitted an interrupted time series analysis, and we did that just in the prescribed because that was available with weekly counts, whereas the dispensed is only available as monthly counts. And basically, you see that the uplift that I described on the last slide ahead of the first national lockdown, we see that here, and that's similar in magnitude to these other sharp peaks up and down, which are the 3 Christmases that happened during the period of analysis. But unlike Christmas, so for Christmas you see a sharp uplift followed by this dramatic decline. We don't see that for the uplift ahead of the national lockdown. We just see this marked uplift and no subsequent decline. Another thing that's sort of interesting from this analysis is that when you look at the forest plot on the right hand side, we can see the beta coefficient for the first national lockdown. But when you consider the period ahead of the second national lockdown, there's, it's flat. There's no evidence that there was any kind of marked uplift ahead of the second national lockdown. And the third national lockdown is a little bit harder to interpret because it was the 7th of January this year. So it comes straight after Christmas, and it's a little bit less clear to understand whether that was actually, just purely due to lockdown or whether it was associated with obviously the seasonal changes at that point. So then going back to the dispensed data, and this is coming on to the stratifications that I showed on the inclusion-exclusion flowchart. So this is when we stratified by the 11 different CVD subgroups or risk factors, whatever, however we refer to them. And so you can see that most of those CVD subgroups were year on year up about 5% ahead of the changes associated with the pandemic. And then we see this decline in year on year growth after the first national lockdown. And that doesn't really recover through 2020 and 2021. Another thing of note is this marked uplift we see for insulin. So insulin was up about 30% year on year in March 2020. And also we observed the switch away from warfarin in favour of DOACs. That's been reported in other publications. So then coming on to some of the other stratifications, looking first to region, we see the most pronounced uplifts year on year in Yorkshire and Humber, and that's associated both with the first national lockdown, and then also they had additional local restrictions through the summer and September 2020. And we also see something similar with London in December 2020, which coincided with the early introduction of Tier 4 restrictions in London. So then, and we also looked at age, and this is actually age in tenure age bands, and we observed this marked decline in year-on-year prescriptions in the oldest age bands, particularly in the 90-year-old age band. And obviously, as I said at the beginning, that the only sort of restriction we've made for mortality at this point is to make sure that they were alive at the start, you know, of April 2018. So obviously this could reflect the large amounts of mortality that have been seen in those groups and that's been reported elsewhere. So then we also look by ethnic group. It's quite hard to pick apart the trends here, but things to note is that we observed this almost delayed uptick in the other Black background and Caribbean ethnic groups. So they actually peak in April 2020 rather than in March 2020. And also of note perhaps is that we see the deepest year-on-year declines in the missing ethnicity group, and that group already had the lowest of year-on-year growth pre-pandemic. So coming back to the CVD stratification by the CVD risk factors, and this is turning then to what we're calling the incident dispensers within those groups. So basically the first time that we identified that an individual was given an antihypertensive or a lipid lowering medication. And so if we look, say, at the top line, which is the antihypertensives, we can see that in the pre-pandemic period, almost 100,000 people a month were being given an antihypertensive for the first time. And that really crashed down to almost half that level following the first national lockdown. There was some recovery between lockdowns, but it really plateaued with the second and third lockdown. And it still remains markedly lower than pre-pandemic. So if we compare sort of spring-summer 2021 with spring-summer 2020, there's approximately 16,500 people less per month being commenced on antihypertensives and 17,500 a month being commenced on lipid-lowering medications. But interestingly, when we look at type 2 diabetes, which is the pink line here, you can actually see that comparing the same two time periods, there's actually the type 2 diabetes incident medications are actually slightly up, which given what we know about reduced screening and what's suggested from the antihypertensives and lipid lowering may suggest, and as has been reported elsewhere, that there's been an increase in the prevalence of type 2 diabetes in the population. So what we have then gone on to do with these data here, and particularly just considering the antihypertensives, is we made an estimate of the total amount of people that were missing to be commenced on antihypertensive medications since March 2020 until the end of our data analysis period, which is May 2021, and that's about 335,000 people. And we also looked at the characteristics of the people that were put on incident antihypertensive medicines using data back from 2019 and considering their characteristics with respect to age, gender, smoking, and type 2 diabetes. And using that information, we were able to calculate a weighted Q risk score and use that information as the baseline settings within the treatment model from the NICE hypertension guideline NG 136. And so from there, we were able to estimate what the non-treatment how the non-treatment of antihypertensives can be converted into CVD events. And so we did that under two scenarios. So the first scenario is assuming that non-treatment would be ongoing for the duration of that person's life. And under that, deterministically in that model, that would amount to an additional 9,000 CVD events were that to continue. Obviously, that's quite unrealistic. So then we did a second scenario where we assume, well, what if the treatment were to commence after 5 years? And you can see that dramatically reduces the number of additional CVD events. So I think it just goes to underline how important it is for us to find ways to identify those people who have not initiated on CVD treatment and to be treated. So turning back to Reecha, this is a tool that we've also developed as part of the project.
Yeah, so this was just to show how we can use medicines quite dynamically so that you don't have to hard code them into your code. And this is something Rohan has developed. So it's a dashboard just to look at medicines trends. So on the left-hand side, you can see that the chapter, you can pick the BNF chapter. So here we've got cardiovascular system, and then you can pick the drug. And then if you submit that query, you get the difference in between prescribed and dispensed drugs at the time periods that we're looking at. So the dispensed drugs are on the left-hand side and the prescribed drugs are on the right-hand side. And if you go to the next slide, yeah, so this is just looking at a kind of a different drug. So this is looking at all the DOACs and how the trends have changed, because we know, as Caroline said, from other work as well, that the DOACs and warfarin have really diverged over this period of time. And actually we can now see that. And for the first time, we can actually look at prescribed and dispensed drugs differently, but also together. And for the first time, also look, as Caroline's demonstrated in the analysis, link dispensed medications to individual characteristics. Next slide. So just to conclude, I think the key messages from our analysis is that the pandemic has clearly been associated with marked disruption in both prescribed and dispensed medicines that are used for cardiovascular risk factors. And we can see uplifts ahead of, but not after, the national lockdowns. And importantly, the risk factor detection, viewed through a medicines lens, hasn't returned to pre-pandemic levels, but the underlying risk factors must largely be there. But lower initiation of patients on the cardiovascular risk treatment will lead to additional future events. So we've estimated from this analysis 9,000 over a lifetime, but as Caroline said, that's probably unrealistic. However, what we do need to begin to understand is how we can actually target that treatment so we can get back to pre-pandemic levels in terms of identification of these patients. And to say that a medicines lens can be used to complement studying the diagnosis lens within electronic health records to actually monitor healthcare trends and service provision. So it's just left to say thank you to all the people who have contributed to this work, who are listed here. And I'm sure there's lots more, and sorry if we've missed out anyone. And we'll stop there.